but he's been in the United States since 1986. He and his family lived first in Washington, D.C., and then they moved to the Orlando area, where they now reside in Celebration. Dr. Ramirez is a former practicing physician who was educated at the National University of Mexico. He also holds a Master of Business Administration degree from the same university. Before coming to Orlando, Dr. Ramirez worked for the Association of University Programs in Health Administration, which is a national association that represents university programs all over the United States. Since coming to Orlando, we successfully recruited Dr. Ramirez to work at UCF in 2006. So he's been there 14 years now, and he is a wonderful and very active part of the faculty at UCF. But the one thing he can't do is keep his feet on the ground. He travels the world constantly and knows a great deal about many subjects. And today we've asked him to talk about World Mental Health Services, where the United States stands, and where other countries stand in relationship to America. So if you would, please join me in welcoming Dr. Bernardo Ramirez.
Thank you very much. Thank you, Aaron. Thank you. Let me see if this works. I think it's working. So thank you very much, Aaron. Thank you for your kind invitation. It's a pleasure to be here. I've been in the club a couple of times in the past as a visitor. I know you're very active and you are always looking for ways to expand your knowledge in different areas and be challenging yourselves into learning about different topics, sometimes that are not your main topics of your careers and your professions and your main interests, but that enrich your multidisciplinary approach to life, and as we all try to do. So I'm very happy to be here. When Aaron asked me to come and to prepare this presentation, I was very interested because mental health it's a real interesting and complicated problem, and I am basically a health administrator, but some of the courses that I teach deal with the idea of healthcare systems and how they resolve problems, and I teach also a course on global health that basically looks at different countries and how everybody develops their own solutions for problems and that kind of stuff. So it was good. I also, at the same time, just as a reference, I had been participating in a research project. We just moved to downtown campus, so I was also telling Aaron that maybe it's a good opportunity to engage some of our new faculty that are here close to Winter Park with the activities of the University Club. But in the program, we were doing this research on mental health and migration, which is a big problem. And migration can be taken in a very broad way. I mean, so sometimes we hear the way migrant or migration, and we probably focus on one type of migration of either place. Actually, the country, the U.S., it's a country of migrants. Most of us here in this room come from somewhere else, 2, 3, 4, 5 generations back, but come from somewhere else. And that's one of the richness of our country. But also migration, consider as migrating from, like, say, rural to urban, or from one type of urban to another, or Aaron was just saying that his kids are going to California. So California, Florida, North England is not the same. there are different conditions and different kinds of situations and populations. So migration is a complex topic, but but we were very interested because Orlando is a focus of migration of different groups of people with different needs, and we were kind of studying what is, and he started the studies in Europe, which also has become a very important topic in many of the European, this was in Germany, but in many of the European countries, the different ideas on how do you take care of healthcare of migrant populations. Not just from the perspective of do they, if it's a national health system, they probably fit in the system. If it's one like us, that they have to buy an insurance or depend on Medicaid or Medicare or whatever other form of financing, it has different complications. But also how do you take care of those people that are in a different transition moment and have some mental health issues? So we've been studying, you know, how do you do that, and studying different healthcare systems in different places to see what's covered, what's not covered, what is more common, how do people access healthcare when they have a mental health condition. So I'm going to try to be brief. I prepare some 25 slides, and most of them are very visual. And the intention is not for you to look at the detail of the thing, but it's like a big map, and basically with colors shows kind of like tendencies or places that have more or less of this type of condition. Many of the places that I use to research and prepare this presentation are very interactive and have web pages that are very good, very interactive, relatively user-friendly, that you don't need to be an expert or a mental health specialist to go and search on that. And I'm happy, as I said, I'm happy to provide a PowerPoint that has all these links. So in many of them, I'm going to show you an example of what it is, but once you go into those pages, that I'm not going to go here because of the time, and I'm not even sure that we have internet. Maybe we do, but I'm not going to do that. But you are going to be able to do that and explore in more depth. I just want to show you some images and some ideas that maybe help you understand kind of like the big picture of what the situation is and the problem is. And I'm trying to make comparisons with other countries. So that's what the presentation is going to be about. I hope you enjoy it. And of course, I don't know if there are like questions during or after. Maybe after, right? Or if somebody wants me to clarify something that is on the slide, I'm happy to take any question or comment. So okay, so let's start here. So first of all, health since many years ago, since mid last century, the WHO came up with this definition of health that you see there, which is a very complicated definition, because originally health for a lot of people is like, I'm sick, go to the doctor, relates to medicine or other professions that take care of your health, and is usually related with a condition or a disease that it's clearly identified. It's not so subjective. It's kind of clearly identified. But as you see, it's not the mere absence of disease, but is the complete state of well-being, social, mentally, and everything. So in a way, we can say that achieving health is a very complicated thing. Most days we're not healthy because we wake up, we want something, we want a new car, and we don't have the new car, or the car that we want is not the one, or we want this, and then we get a little anxiety, and maybe our heart beats a little more, and then something else, and then I get a little ulcer active or whatever. So the complete state of well-being is very difficult to achieve. So it's made life a little complicated, and sometimes it's difficult to evaluate in a real sense the effects and why health systems are successful in one place and not in another, because we cannot see many of the components of health systems. So that's one thing. The other thing is that mental health disorders, and I'm using the word disorders, it's really a continuum. It's a continuum of events. So mental health some people think that some conditions of mental health is not a disease. So you might be stressed, and some people don't catalog that as a disease. It's not that I'm sick of stress, but I have a condition. I am not in complete health because I have this stress for whatever reason. So, or you can be, you can have minor conditions of different kinds of health, mental health problems. So the first problem is that there's a sort of continuum from very light manifestations of some of these things to more complex, then becomes chronic, then becomes more acute, and then becomes a disease. And then you end up in a category that is clearly a mental health illness, or you can clearly identify that you are in a place where you have a disease. So that's why I want to use the word disorders, because many of the things that are mental health, that relate to mental health, a lot of people don't feel that they're mental health. So there's also, well, we're going to see that, but there's many reasons for that. So there's an estimated 1 in 10 people in the population has some kind of mental condition that is clear. But I think much more of the population have some kind of condition that doesn't let you be at ease, that you have a small manifestation of some kind of mental condition. So that's important. It's usually very poor reported because it's very subjective. And at the end, I'm going to come up with a slide that shows 5 or 6 things that we're doing now, and that it's pointing into directions of how to solve problems of mental health in a different way with some different practices. But it's very, very difficult to report. It's relatively subjective. There's stigma. There are many things that make mental health difficult to report. So the data is relatively uncertain. When you look at data that is there about different health departments, different organizations, different places, many times it's not that certain. There's some uncertainty on the data that's there, so it's not that clear. One of the things that I want to share with you is that there's also a response of the health systems that vary from primary health care, which is basically preventive health care. The best definition that I've heard of primary health care is that it's the anticipation of risk with the best possible cost-effective solution. So primary health care is not what happens when you go the first time to the doctor, or is not the first contact of the doctor, but it's the action of the health system to anticipate some kind of risk that you have, and then do it with the most cost-effective way. So it goes from that perspective of anticipate before anything appears, to anticipate those risks and to do some of the activities that we call preventive care. So it goes from there to ambulatory care and different kinds of NGOs and different kind of groups that solve this in a more society, let's say, outside of the sphere of the health organizations, many times connected but not exactly in a hospital. Then it goes to ambulatory care in healthcare. Then when it becomes chronic, it can go into or you have acute episodes, then you can go into hospitals. The tendency now is to have like wards where people are taking care of some mental conditions. There are less and less places that are like psychiatric hospitals as they used to be, and there are few countries that keep this level of care. There are a few, and there are reduced kind of cases, extreme cases of mental health problems that require to have that person in the hospital, and there's specialty hospitals. But also the treatments, and we're going to talk about that at the end, the treatments for all that has changed very much. The idea of electroshocks and stuff like that, I mean, it was more common before, it's less common now. And so So this continuum of care is important to take in consideration, because when you talk about something there, it might be in the different stages of that, and it might mean something different. And that's why sometimes it's not easy to understand. So it's estimated that 1 in 5 Americans will experience some kind of disorder this year. So 1 of every 5 people that are here are going to have some kind of mental health disorder. So you're going to have so count them and see which one. But so it's a very common thing. But many times it goes unperceived, or is so light that you don't really affects you in a significant way. Many times it does. Many times it accumulates, etc. So it depends. 1 in 25, so maybe just 1 in this room or 2, might end up in some kind of serious illness. Might end up having something that it's like a more serious condition that requires more. In every one of these places, I'm going to point to these references, and they're all URLs to go into the internet. Because, for instance, in this case of the different countries, there's a very good report that it's online, and you can go and research it, where it gives you studies of all these countries, and they have very small paragraphs and say exactly how in each country so if you're interested in one or other country for whatever reason, you go to that link, you choose that country, you go to a section that says mental health, and in a little paragraph explains to you how they deal with mental health there. But because of the time that we have here, this is not an academic kind of presentation to try to compare in detail all these healthcare systems. I would do that with my students probably, or we have them do that in their assignments. But here we're just going to see some of those things in general terms. But I wanted to be able to provide those because many of you might be more interested in going in depth to those things. Some of this data is from the CDCs, and again, the references are right there. So stigma, discrimination are 2 of the things that complicate mental health. And there are many things that we can do for that. Education, health education, things that we do at the level of primary health care, maybe helping people understand that what they have is not a disease, it's a condition, it can be dealt with. And there are tons of NGOs that deal with that. The government also has different websites, WHO. So there's all kinds of information. Now with the internet, we have all kinds of information about that. Discrimination might also be something that might create threats to some kind of groups that feel they're discriminated for some reason, and then they don't want to say that they have this, that they feel that. So they kind of restricts the free access of people and the disclosure of these conditions and the opportunity to address them in an early stage and at a time that they can be preventable. So that's important, and there's also a reference there for that. Now, very quickly, we know that healthcare is not about healthcare services. It's not about what we do with the doctor, because there's something that's called health determinants. So there's a series of determinants that makes us healthier or not healthy, or that facilitates that. And really, most studies say now that healthcare services are 10%. So the things that doctors can do and nurses and you can do in a healthcare center and with medical science is relatively small. 20% genetics, probably of the conditions of the people, things that condition some mental health illness or condition. The environment is 20%, so where people live, etc. And the 2 last, environment and health behaviors is 50%. So now you know that it's more important to eat healthy, to go to exercise and all that, than to take a medicine or do other activities. But usually those 2 are very important, and now social determinants is something that healthcare is very interested in doing. It's kind of like a new trend. I went to the College of Medicine in December. There was what's called the Grand Rounds, which is this when somebody wants to give sort of a breakthrough kind of idea. to the medical group, they do something called grand rounds. And so everybody goes there, and then they discuss this topic. So they invited this person, Pomeroy, that is a director of a big NGO, to come and talk about social determinants. Because what's happening in many places around the country and around the world is that hospitals, healthcare centers, doctors are now looking at beyond healthcare, beyond medicine, beyond the hospital. So they know that patients don't get well because they don't have good living conditions, because they don't have good housing, because they don't eat good food, because different things that don't let them be healthy. And so hospitals now, Brigham's Women's and big hospitals, the Cleveland Clinic, these huge hospitals, Mayo Clinic, they have these programs now, and they're doing these activities and these programs where they basically, instead of giving the patient a bunch of medicines, they give them a bunch of vegetables. And instead of worrying about they're going to come back or something, they look for ways to provide good housing to somebody. So they have an hygienic condition in their house and all of that. Many of these things have become more true, and so that's why it's difficult to just judge directly and see who's doing best and who's doing worst, because all these things have so many variables and depend on so many things that sometimes when you say, well, this have this percentage of this kind of disease, this country has this percentage, or here we have this, you're looking at a very static and partial information, and you cannot really tell if these people are really doing well because they have a low indicator of this or that condition, or how are they doing that because of that complexity. So we usually finance differently. We spend most of our money in healthcare services, which are just responsible for 10% of what happens with us. And we don't spend a lot of money in behaviors. Insurance companies don't give you a big bonus because you eat well or something, but mostly things related to healthcare. So there's a little imbalance on that, and that will have to find ways. And many healthcare systems around the world, if you look at systems that are very good, and someone says, well, France, it's a good healthcare system, or this other country has a very good healthcare system. Well, maybe they're spending differently their money. Certainly, nobody in the world is spending as much money as the U.S. is spending in healthcare. That's for sure. So when you measure efficiency, we tend to not be at the top of the list. So this is just a big scheme to again tell you that healthcare is conditioned to different things. It's a very complex, it's a system, first of all, and then it's a complex continuum of events that produce different kinds of things. You can be efficient, what's called efficient, when you use resources to do more consultations. So you can be efficient doing that. But sometimes you're very efficient and you have indicators of productivity that might be high, but you're not very effective. You don't have good outcomes. So they're not good outcomes. So you are looking at a lot of people that maybe you didn't have to look. So you're almost spending useless resources on something. So it's important to understand, and that's the only thing that I'm going to say of this, that we might be very inefficient because we use a lot of money to produce relatively not so many services, and sometimes we don't have really effects on what we do. So then that is almost spent in vain money. It's not money that's well spent. So being very efficient doesn't guarantee that you're going to have good outcomes. Having big productivity doesn't mean that you're going to have big outcomes. Having outcomes might not mean that you're being efficient. So you might want to have outcomes and then look back to the efficiency. So all of them combined, and it's a thing that it's in a system that depends on so many factors and so many elements that it's complex to study. So now we are in a process that we look at value. So people say now healthcare wants to look at value. So value is something relatively new, not only in the US, it's a worldwide thing. I mean, most of the European countries are on this systems of value-based management, let's say. And it's a big movement. And in a way, regardless of where the reforms go and what things are doing, most systems are moving in that direction. Most systems are moving with this concept of value. What we want is not just to have access to healthcare. So there's this thing that's called the iron triangle here, where healthcare depends on the combination of those three things. Depends on having access, depends that the access, once you have it, has quality, and that the access with quality is cost effective, that you can pay for that. Because if you don't keep that triangle, and that's, our profession is about that. I tell my students, they're gonna pay you to do, and we go to a class of geometry, and I say, do you remember triangles in geometry? Okay, there's one triangle, okay, that's called equilaterals, right? Which means that every one of the sides is the same side. So that's what they pay you for. The reason they're paying you as a health manager is because you need to keep this balance of the triangle. You need to maintain good cost with good quality, with good access, balance. Because it's very easy to address one of those three things and neglect the other two. So if you give me a lot of money, then it becomes very costly, and maybe I take more people, so there's more access. But maybe the quality is less because I give them very poor consultations, no medicines, but everybody has access. So maybe the quality goes down. So the trick of health management, of the people that come study with us, is to keep the balance of that triangle. And that's why many times we see reports that measure access or quality or cost, and then we blame on that, but we don't see the whole picture, and so we might be misjudging what we're seeing. So it's important. But the important thing of this is this idea is that value is quality at a cost-effective way. So you have to have access, of course, because if you don't have access, that's the first part. If you don't have access, you cannot have quality or good cost. And in a way, our reform started like that. We had people that didn't have access, so they give access to everybody. That's the first part. Now, then we see that they have quality within that access, and then we try to see that quality, that we diminish the cost, and we find cost-effective ways to treat those people. So this is something that we do in healthcare. And this is the last one to understand this whole process, and then we're going to go to the several slides of the different conditions of mental health. But basically, these elements are very important to keep in mind, that healthcare is not what happens when you go to the doctor. Healthcare value means that it's a continuum that this was developed by a management thinker in Harvard that's called Michael Porter, that was very famous for creating this thing that he called a value chain. So he said the important thing of an activity that you do is not that you do that and produce something, but what is the value of the chain process that happens to that activity to go through? What happens before? What are the inputs? It's almost the system analysis. What are the inputs? What happens in the process? What are the outcomes? So where's the value of the chain of events, which is the same thing here. You can have an excellent doctor here, but there's no population health, there's no risk understanding, there's no primary health care. So this person gets all these people with a lot of complications, with no good diagnostics, with no good behaviors of the patient. So he's not going to develop that in the time that they come to the hospital. That has to be developed as part of this chain. And then once this thing happens in the system, then there's something afterwards. You have to have good lifestyles. You have to follow up with patients. You have to have a chain of services that support your care through the process. So that's what many of the good mental health systems are doing around the world, the ones that are effective and work well, that they look at this as a process. So they are not looking at if they're going to change the psychiatric hospitals or if they're going to give them this medicine. They're looking at this process and trying to make it consistent and trying to address the whole idea of the process. And I think the ones that report better results are the ones that have a more connected system. Also, now we have an additional problem in our generation, which is longevity. Look at all of us here. My father died when more or less at my age, and I remember that he could not do a lot of stuff that I can do. So, and it's just one generation. So my kids are gonna live probably 90, 95, and they're gonna be like we are at 60 or 70. So, and so on. So longevity is a condition that's happening all across the world, not only in developed countries, but all across the world, that extends the chronicity of things. So some things that before people had for 3, 4, 5 years and then they would die, now they have for 10, 12, 15 years. And so it develops forms of mental health in this case, or conditions that transform themselves through time in this chronicity and present things that we never saw before, and present challenges for that idea of longevity. So longevity is good for those of us that are enjoying it as it happens, but it might be very complicated to solve in this kind of problems. So chronic care has that first problem. The second problem of chronic care is coordination. Our systems are developed for acute care. Hospitals, doctors, everybody is developed for an act of medicine, but it's not developed for chronic care. Chronic care, according to some of the experts that talk about chronic care, require the interaction of at least 5 to 8 doctors for any procedure. How can we do that if our medical record is with Dr. Ovidio, and I have to see this other person, and yeah, maybe their office is going to send something, but I don't know what x-ray they did it, and then I have another one, and then all these people prescribe me different medicines, and there's no one person that coordinates all of that. They work in different systems. They probably don't know each other. I mean, sometimes they do. Sometimes their groups are coordinated to do that, but not everybody's coordinated to do that. Sometimes it's just like by coincidence that you're doing this, and then you end up with 7 doctors that are looking at your condition and probably complicating life. So that is a thing in chronic care that doesn't happen in acute care. In acute care, most of the times it's easier to coordinate. It's one event that happens in a relatively short period of time, and the doctor or the system has more control on how to address that. So, and mental health is many times has this problem of this chronic condition. So, leading causes of death, Alzheimer's disease is number 6 in the U.S., which is a big problem for us. And suicide has grown very much, especially suicide of teenagers, of young people. And because there's more mental health conditions, there are more people that are depressed, there are more people that are a little desperate, that are stressed, that don't know how to solve their problems, that they don't have the assistance to do that. And so these are problems that are increasing, and before they didn't appear in these charts. For adolescents, for instance, the mortality causes of death is the leading causes of death is first accidents, second suicide, and third one homicide. So those are the leading causes of death for adolescents, for the group of adolescents in the CDC report of mortality. So it's very disturbing because all of that produces a very different tense situation. So we have to think about that. This is one of the pages that's very interesting. Aaron was asking me, can you help us understand different countries? This is a page that is very interactive. Once you go into this link, you can do several things with the page. One of the things that you can do is that you can do it in time, so it goes through different years. This is the last year that the data in 2017. You can go through different systems, and you click here. For instance, you see Alzheimer's. This is the U.S., and this is France. So you see Alzheimer's is bigger in France than here. So the number of people with Alzheimer's disease is larger in France than here. They have a better healthcare system. If you look at the ratings of healthcare system, France is the second one in the world as a good healthcare system, and we are like number 16 or 18 in the world. So we're not one of the best healthcare systems. We have probably one of the best health doctors, hospitals. So if we try to compare Mayo Clinic or Cleveland Clinic or something with other hospitals, maybe it's number 1. But that doesn't mean that the health of the population in the U.S. and probably our health is closer to the one in France or those places because we have access to healthcare, we have access to those good systems that exist. But the population in the country doesn't have access to that. So we really need to look at that. And so if you click here, you see anxiety, depression. You see here also depression is kind of similar. Schizophrenia here, see schizophrenia there. So bipolar disease. So you can click on all of these and then you can combine different countries and compare different countries. You just click here and put Israel with the US or whatever, and then gives you this information. This is usually done, which is another interesting thing, in something that's called DALYs or ELDs, but mostly DALYs is used, this measure that's called DALYs, which is disability adjusted life years, which is how many years you are going to lose because you have this condition. How many years of life and productivity. And this is something that changed the world of healthcare, like around the year 1990, when the World Bank did for the first time a report that was focused on health. Before that, the report of the World Bank was on agriculture, on industry, on this, on tourism, on whatever you want, the annual report of the World Bank. The first time they did that, it changed the face around the world, in the US too, but around the world, because they basically said healthcare, bad healthcare, has economical repercussions in the system. If you have people that are sick, that are not productive, they lose years of productivity, and so you are losing economical potential. So for the first time, I was at the time coming from Mexico, but a good friend of mine was in the Ministry of Health, which is now the president of the University of Miami, and he became the Minister of Health, and he went to work for the WHO. When this happened, he was working for WHO, and he's one of the persons that came with this idea, because they were looking at outcomes. They say, we don't want the World Bank and all that to continue reporting on how many diseases are there. Who cares? I mean, of course we care, but what does that mean? We have this index of mortality, we have this number of people that are sick of this, so what? So the important thing here was let's find indicators of outcomes, of productivity, that we say, okay, so we have those indicators, what do they mean for healthcare? And that's what we need to look. So when you look at this kind of information, usually it's done in that kind of data, which is a relatively new stuff, and I mean new, 30 years, but I mean newer, that has been developing this notion in people that you have to pay attention to those things, because they're not just important for your health, they're important for the general well-being of the world, of the economies, of everything. So ministers of health were able to go to ministers of finance and say, you need to give me more money because we're losing all these years of productivity. So I need to improve these indicators so we become more productive. So healthcare became more visible in the spectrum of financing for health services around the world. So these are the mental conditions, and I don't know, could somebody just time me? Can you tell me when I'm like 10 minutes to whatever? So I don't want to keep you here forever, but 10 minutes more or less. So these are the different conditions that I looked into to show to you. And I will give you, and I'm going to go now through some of the slides that continue, so you see those conditions in these maps, where you will see the US and other countries, and you will see the scale, and you will see what is more or less the situation of the US compared to the rest of the world. You'll see that in some of them, unfortunately, we're leading the world. So there are things like the use of some substances that we're leading the world. There are some things that we should not be leading the world. And eating disorders, I discovered that we're one of the leading countries in the world on eating disorders. And but there's some that we're okay, like alcohol. We appear to be okay compared to other countries. There are countries that have more problems. And if you look at the previous one and you look at lung cancer, France has a big problem because still a lot of people smoke. Here, a lot of people don't smoke. So there's some things that we tackle well. And mental health is one that we need to tackle better. So you see things from depression, anxiety, bipolar disorder. So some of these things, maybe you say, yeah, I have that. I mean, I have a little bit of that. I'm not like like a case to go to the psychiatrist, but I have a little bit of, I'm a little bipolar. So I have a little bit of depression or anxiety sometimes. So that might be a condition for most of us. Then you start going down the eating disorders. I was amazed to see that it was very big. It was especially big in the U.S., and it was especially big in women for some reason. I mean, I need to study it more because it intrigued me. Like, why women? I usually eat more than my wife. But it's more like anabolia, like not eating right. It's not eating well, but it's not eating the right kind of stuff, not eating too much. So schizophrenia, which starts now being a disease more than a condition, you know, in some not so severe schizophrenia is still a condition that can be managed, you know, relatively okay. But some bigger conditions, when people start losing sense of reality, then you need to take steps that are more severe. So alcohol, and this one, drug use, the use of drugs is really huge. So I'm going to go now and show you. In this case, I'm putting those overlapping these two slides, and they're the only ones that are a little smaller than the others because I wanted to put the two of them. But you see on this one the U.S. and on this one the world. So you see some conditions, and even though the bars seem like the same size, see that the percentage are not. This is 6 and this is 3, because they made each one of the bars kind of for that bar, and so they were not meant to be put together to compare. And I didn't really put them in one bar, but I just put them together. But you see that we are pretty much higher on some areas here. You know, like anxiety, for instance, almost double of what's a world indicator. Depression, we're 4.8. Here's 3.4. So alcohol, we're not bad. You know, but still compared to the world. Chronic drug use disorders, this we're also much higher. You see this is 0.9 and we're 2.0. Bipolar disorder, we're more or less at the same place, and eating disorders, we're pretty much like double of what the world thing is. And schizophrenia, we're kind of like a little over, but not too much. But you see that, unfortunately, compared to the standards across the world, which don't mean anything, because it's, you know, so many people in so many countries with so many different conditions that dilute into something that is not that meaningful, but still is a way of comparing. It's the U.S. is not doing very well. Then France, again, because Aaron asked me to do that, and you see that we're closer to France. He's 6, 4, 4, 3, 1. So they have here alcohol. Apparently they consume less. I find it difficult to believe with so much wine that they eat. But probably is alcohol measured as hard liquor or as intoxicating with alcohol and stuff like that. And then the others also are we're a little worse here on these ones, but more or less the same. So with France, we're not that different in mental health issues in these issues. Then you look, for instance, anxiety. See, the darker colors in this case are higher percentages, right? So see the countries with anxiety. A lot of the European countries, Australia is big on that. The U.S. and Canada, or most of North America. But you see other countries in Africa, they probably they have anxiety, but maybe not at the level that this is. Also, the underreporting. Remember that this is not very accurate data, because in some places they collect more information, in some others they have worse information systems. They do, some of these reports do them by questionnaires, and others by analyzing reports of the WHO and others. So depression, look at the US or look at the numbers. You know, if I live in Greenland, I probably would be more depressed. But you know the story of, we went to Iceland, and the story is that of course when they expelled these Vikings from Norway, they sent them to Greenland, but they didn't like it, so they discovered Iceland in the way. and then they rename them different. They say this is going to be called Iceland, and the other one is going to be Greenland. So people move over there, not here. So they leave us alone. So if you've been in Iceland, it's a wonderful country. It's really such a different country than you would expect. People are fabulous. So anyway, so you can see here how this of course the U.S. again continues to be very prominent. So you have here eating disorders. Look, China and the U.S. are kind of like the top of the scale. See, so and then here you see schizophrenia. So we have our share there. Australia apparently is a little stressed. And then you see some of the graphics. I didn't want to put a lot of graphics here, but you see this one on substance abuse, the prevalence of mental health and substance abuse. You can see here the U.S. So you see that here this is the mental abuse, substance abuse rate. So you see that it's pretty high, and then this is the Oh, the rate that they use to measure this, that's the cycle rate, but this is the rate that they use. So basically we are at this level of the scale. There are other countries up here, so you see all these countries here, which have relatively high and they're out in the scale. This is the world, the average of the world. And people are in different places here. But the US is pretty high. And then the last thing that I wanted to look is at happiness, right? So our Constitution says we don't have the right to health. We're one of the few countries in the world that has not a right to health. And, but we have the right to be happy, right? Because the Constitution says that we have the right to pursue happiness, so that we need to be happy. So I think for all of us it's important to be happy, because that's our constitutional mandate, right? To be happy. So they've done this report since 2012 about happiness. And it's become now more popular, and they've narrowed down the reports. And I honestly would recommend that you look at those reports if you have not seen them. The references are there, because they're very interesting, because they were starting rating happiness. And it was very subjective. They would ask people, are you happy with this? Are you happy with that? What do you feel about this? And then they would put together those things. Now they do some polls that are a little more like focus groups and a little different, and they try to be more specific on the results. And so it's become better, the kind of information that comes. But the last two reports, the one of last year was happiness and migration, because precisely there was such a problem in migration. So they were trying to measure if people that migrate are happy, if people that leave, that is left behind, is happier than the ones that come, if people migrate inside the same community to different states or to different locations would change the level of happiness and satisfaction, life satisfaction. And they discovered very interesting things. And this year, one of the things that they found around the world that was very important, not only in our country, is that there's this idea that communities are a little stressed, a little polarized, that there are a lot of political events in the world. Now, it's not only our country, but around the world there are many conditions that are similar to ours. And that people are not being so happy or being happy depending on how that works, how that performs. As just in a nutshell, the US in 2018 was around number 16 or 17 country in the happiness list. So we were not bad. We've declined in the last, from 2017 to 2019, we've declined in the sense of happiness. So we're still at a rank that is around the same place. We have not lost many points. But they also ask a question, are you happier than you were last year? So you might still be happy, but are you happier or less happy than you were last time we asked you this? And so people say, well, I'm less happy now. So they go to this other rating, and in that rating of 160 countries, the US is 101 on the down of the list. So that means that in the last 3 years, people are not very happy for whatever reason. And maybe more stress, maybe more polarization, maybe something, but people have answered the question saying, I'm not too happy compared to what I was, 3 or 4 years ago. But it's the same with other countries. I mean, it's the same. I look at France. France is kind of like close to where we are, a little better, but it's somewhere there. Mexico is worse than the U.S. So there are countries that have this idea. And so they measure in the last report, if you're interested, they measure the role of government and local communities into your happiness. So this is not migration, but this report of this year is about that. And so I highly recommend that you look at that. Of course, when you measure life satisfaction with GDP, you of course find that people that are more satisfied are the ones that are higher in the GDP. So you have here countries like the US, Canada, Norway. Norway is always at the top of happiness. If you want to be in a place that's happy, go to Norway. Finland just joined the clan, but Norway, Sweden, I mean, we know that they're cold. We don't want to be in Norway. I've been in Norway several times. It's a beautiful country, but they're happy. They're very happy, and so. But it doesn't mean if you look at the schizophrenia and depression and all that, they still have all of that. They're happy, and they have some of those conditions, but they're happy. So I don't know, depending on what you're pursuing. So. One of the chapters, and I wanted to just put this two slides, which are really the last ones. These 2 slides talk about additions and unhappiness in the U.S. And it talks about the kind of additions, according to this researcher that has studied that in the last reports and in the last surveys that have been done, what kind of additions we have that make us unhappy. And if you look quickly, so there's some information here that you see that we are not as happy, but we're also not as bad. But some additions like DALYs for cocaine use, for opioid addictions. So those things were at the top of the list in the world. We've gone up in ways that are very, very, very impressive. We have a lot of research going on that. So these are the kinds of addictions that he discovered in the US. And you see something like shopping addiction, right? Addiction. So work alcoholism, like different things are addictions, gambling, drugs, different things. And some of those, maybe we are part of the contributors to that. Food addiction, alcohol, tobacco, love and sex. He basically put several conditions that people might be addicted to and how that reflects in percentages and again, this report will tell you in much more detail that this is the diseases with the Europe DALYs and the global DALYs and the US data. And if you look at each one of these, mental health, drug use, amphetamines, cocaine, alcohol, all these things that were before, you see that we are at a higher number than Europe and than the world in most of those, which are more specific information. So we are really going into that field. And this is the one that I said at the beginning. There's several things that are happening that will really revolutionize the way we look at our health, not only mental health, but mental health in a particular way. And these are some of them. Telepsychiatry, so not only telemedicine, but psychiatrists. You were asking how many psychiatrists are there in Russia for people. Actually, I read one time that in Argentina, there's the highest rate of population and psychiatrists in the world. So especially in Buenos Aires. So there's this rate about how many psychiatrists there are and how many patients there are doing psychoanalysis. And so now you can do many things with telepsychiatry that sometimes doesn't seem easy. Telemedicine, yes, but like having a confidential talk with somebody on the phone and sitting in the sofa and telling them, what I was when I was a little kid, doesn't seem something that you can do with telepsychiatry, but they're moving. Artificial intelligence. Many things are now gathering information from many sources. And because before they were very spotlight. You go to the mental health doctor or you have a mental health problem and they just see you at that moment and it's difficult to record what's happening and to bring more data to compare you with other cases. So artificial intelligence is doing great things connected to smart apps, to remote monitoring. This is like what we do for elderly people. So now there are body things that measure your stress. So it's not, and some people that might have a crisis an anxiety crisis, it changes your skin, changes the flow of your blood. So they can monitor that at a distance and probably provide you help, even if you don't recognize what's going on. So they're now this remoting, even speech analysis. They're doing things where they can tell by the way people speak, they can detect with some level of anticipation that people is getting with anxiety. And then they match those speech patterns with these artificial intelligence databases that really make all these connections. So it's difficult for a doctor to make the analysis, but it's easier for the computer to analyze your speech and then compare it with a lot of patients that have gone through different levels of anxiety or whatever, and then detect beforehand some conditions that before was not possible. So many of these things that were very subjective, that are difficult to measure, are coming to the place where maybe some of these advances in healthcare will modify the way that mental health conditions can be prevented, and we can have a really healthy system that follows that continuum of care and that value-based management, which is what we want, of course, in the US. But we should be concerned. So it's not a question, but an answer. I think, it's an assertion, I think we should be concerned about where we are, and if we don't change, where we're heading, if we don't really put some emphasis, if we don't invest in some of these things, if we don't really take care of this. And of course, it's a pleasure to be here, and happy to answer any questions if there are.
Thank you, Bernardo. I think a very informative presentation, and I'm sure the members of the University Club are very happy with your presentation. They're all happy.
Yeah, I hope. I'm happy.
Some questions from the audience. Mark.
What is transcranial magnetic stimulation?
Yeah, that's very interesting because for some procedures before, they used to use like electroshocks, what's called electroshocks, that is electroconvulsive therapy. Now they don't use it, and now they use magnets. And with those magnets, they can produce the same effect than electroshocks would produce in the past. So for some conditions, these are, like before, people were afraid to do an electroshock because it's almost like electrocuting somebody, right? So it looks almost inhumane to put those things and give them a shock. But and they decrease. But now this is more manageable. So it's not like a huge amount of electricity goes through your body, but this is magnets, and they can manage that for even milder conditions and actually be therapeutic. And I was reading, and this article will tell you some more, this article that's down here, but I was reading some about that because, again, I'm not a psychologist or a psychiatry, so I don't see patients with mental health disorders frequently, but that's what it is.
I have a question.
I don't have a question. I'm in the medical field, and for the last 20 years, I've had a gerontology practice. Sure. I'm a care manager. So I want to thank you for talking about the PCP, primary care doctors. I spend a lot of my time for my senior patients collecting all their paperwork, all their MRIs, all their CAT scans, all their doctor's notes to go to the PCP so I can have an accurate description of a continuity of care for my patients. Now, in this town, I practice here, so I don't know about other towns. I'm from New York. I graduated. I've been in medicine for 62 years. So what I do know is that when my senior patient is taken out of his or her house, they have to go to the emergency room, then they go to the observation unit, then they might get to the floor. By that point, their meds are all messed up. That's number one. Then what do they get? A young physician with a white coat and a stethoscope who's a hospitalist who has never seen my patient. I would like to see that we could maybe correct that they would confer with their family doctor that they've had for many years. That's one thing. The second thing is, I'd like to see our gynecologists, our PCPs, and anybody else that is prescribing psychotropic drugs for my patient to refer them out to psychiatrists and see a therapist. Thank you.
Yeah. Thank you very much. It's a great comment, and you're absolutely right. We need to do something about that. We need to do something about that.
You said 4% of the population in this country has severe psychiatric problems. Now, 1 out of 25, so that's 4%. Now, what are your criteria for severity? Is it the effect it has on their lives? In other words, if they're working regularly, could they still
Yeah.
be considered severe?
That would be for sure. This is a CDC data. This is one that they tabulate there, and I'm sure there's more specific indicators, but that is one that is very likely when people are not able to function normally in the community. So if you have depression, but you kind of start crying every 5 minutes, and start having convulsions and stuff, I mean, you're not operational. You cannot operate in your community or in your environment. You are in a severe condition. So maybe that is part of it. Maybe the chronicity of the disease, probably the effects that it has on other kinds of areas. When a mental health disease affects also your metabolism, your heart rate, it gives you some kind of heart condition, or gives you some kind of nervous condition or something else that really impedes you to function well. So yes. But it's basically it's a data that is recorded every year in the CDCs, and of course with very specific. I mean, if I would go there specifically to look at your answer, I could find exactly what are the criteria to put people in that category, but most likely are those that you're mentioning.
Oh, thank you, Bernardo. When you travel around, do you see the homeless situation like we have here? It seems like most of the chronically mentally ill are on the streets here, or a lot of them are. And
Yes.
is it as
That is a big
big a
problem.
problem in other countries too?
In other countries, somewhat. I think here is a mix of a big problem with homeless, and a system that we have, which in a way is okay, to be respectful of their independence or their will. And so almost, police don't take them and bring them to an NGO. I mean, they have to almost convince them, and if they go there and they don't want to be there, they come back to where they were. So, and in many countries that's not the case. In many countries, you find somebody that's homeless and probably speak up by the police. So somebody reports this person is kind of wandering around. So the first, and then yeah, I mean, like maybe it's considered like you're trespassing or you're annoying other people or whatever, and so they would take more care. So I think we see less. And one place where I'm always shocked is Chicago. I go to Chicago 2 or 3 times a year to meetings and conferences. I've been in the metro sitting next to a person that's really mental, it's a mental condition, that is yelling at everybody and looks at me and says, "So what are you looking at me?" And nobody does anything. Nobody even calls 911 or anything. Everybody thinks, okay, that's okay. And I've seen some even aggressions and stuff, and I say, well, somebody, one time I was gonna call, but I was next to that guy, so I say he's gonna probably stick a knife on me or something. I don't know what this guy has, but really situations that should not happen in a developed country. But in some developed countries, I've seen similar things. I mean, I've been in France, and I've seen people that are kind of homeless and wandering, and they're not picked up by the system. But over there, they have a national health system, so everybody has the right to some kind of health care. So maybe they will take him to, not to Yale, but to some kind of health service.
Mental hospitals, state mental hospitals?
Yes, they had hospitals, but they are trying to move down the ladder, as I was explaining, and they're trying to move the mental health services down to wards in hospitals, so they're more accessible and distributed in the population. So, and they're not so stigmatized, that you're in this cuckoo house,
Is there a very good correlation between the countries involved in war
and mental health. I would expect
Yes.
mental health really to be a problem and really
Yes.
deteriorate in those countries. Conversely, in Scandinavia, they're peaceful. They have a good income, particularly Norway, although Norway was involved in the war, and Denmark occupied for a couple of years by the Germans and all that stuff. But still, they have very good income, very good social support, very honest politicians and the whole works. So they should be happy. Beautiful countries and all that stuff.
Right.
But what about that correlation of
Yes.
those involved in war and the mental health?
Yes, and if you see the numbers, there's some of that. I mean, you see countries are in war, but some countries have these chronic wars. I remember having a peer from Lebanon, and he lived in Beirut, and he worked for the American University in Beirut, and it was difficult to even send him a ticket. He had to fly to one of the islands in the Mediterranean, and then we would fly him here. But he was like he had been like 15 years under bombardment every day in their city, and he was like, okay. I mean, he said, you get used to that. I mean, we all have things in our trunk, so we listen the same way you listen to the weather. We listen to where the bombardments are going to be in the city this day, so we go use the green line instead of the other one. And then if we are in a house and I cannot go back to my house, then I have to have my little bag in my trunk, so I stay there for 1 or 2 days until the bombarding finishes, the shelling finishes, and then I can go back home. But people in a way develop, so they're resilient, and they develop this kind of like almost immunity to those things that you would think, if I'm in the middle of that, I would be. And just in the Second World War that you were referring, just think of this idea of the people in London that every night you go to bed and you don't know if a bomb is going to fall on your house. Doesn't matter where part of London you live, right? So that's a very, I think, but after some time, maybe people got used to that. They would go sleep, and yeah, some of them wouldn't wake up the next morning, but it was.
I have a question here.
Huh?
Places like that, Russia and Poland, places that were really getting it both ways for a lot of years.
Yeah, but it's amazing when I went to Russia and to most of these countries because we were doing a USAID project in hospitals, and for many years, and I was surprised to find that yes, it was like a police state, and it was they didn't have a lot of liberties, but there was no violence. I mean, you could walk in the middle of the streets at night, 1 o'clock in the morning, nobody would come close to you, and there was not a police every corner. Actually, some of my friends from some of those countries, when they came to the U.S., pointed to me for the first time. One of them says, "Is there a revolution or something in the U.S.?" I said, "No, why?" I see so many police cars in the streets, and they have these big guns on inside the car, and they're almost one in every corner. I said, "Really?" So I said, I've not noticed. But then I started looking, and yes, like there was one every corner, and then you turn around, there's another police car. Then you turn around, there's another police car. I said, maybe that's the image that they get. And I said, somebody coming from the Czech Republic or something like that, noticing something like that, that means that in their country, they don't see a lot of police or heavy armed police. If there's a police, it's a little guy with a stick. I was always surprised in Russia that the police don't have any weapon. They just have a little stick. But they just lift the stick when you're driving, and people, doesn't matter that you're coming in a Mercedes-Benz, boom, will stop. And the policeman approaches you and tells you whatever, and you come with some kind of agreement with him, gives you a ticket or not, and then you leave.
Let's have
Yes.
a couple more questions.
Okay, slide after slide of yours, I keep thinking to myself, education. Who
Exactly.
is going to educate doctors and nurses to think and that they're part of a continuum, et cetera? But my question is actually, in any of the countries you've looked at, is there a real effort to educate young people, that is to say, grade schoolers, and raise them with some kind of idea of how their bodies work, what the society provides them as they're growing up, and what sorts of concerns they should have about being a citizen in a community?
Exactly. I agree 100% with you. Napoleon will also agree, because when he was asked when I should start educating my kid, he said 20 years before he's born. So they have to start educating you so you can educate your kid. But you're right. I think education, and that's part of primary health care, not only for the population, but also for the providers. We just opened a new class in UCF that is one thing that's called general knowledge. So it can be taken by any student in the university. And it's almost like civic healthcare. And the idea of that class is really to educate students in what is your responsibility, your civic responsibility to maintain yourself healthy, to collaborate, to promote healthy behaviors around, to make sure that the system functions well and takes care of people. So we explain to them what the health system is and what are these functions. But really the objective of the class is to create some civility related to healthcare. And people, doesn't matter what kind of career they do, it's not part of our department, it's in our department, but it's open, it's one of the 101 courses that it's open as part of the general knowledge that students should have around the university.
Has there been any studies with Chernobyl?
Yeah.
What are the?
Oh yeah, well, I don't know exactly the results, but I know they did studies about what happened there. Now, in the Times, they didn't do a lot of studies probably in Russia. The ones I did over there, we don't know what they are. but the ones that were done, by international agencies and show that it was a big disaster and the consequences of that. Right, the consequences of that. And I think many of those populations, well, it's almost like we have not a Chernobyl, but we have Flint and other places, populations where there's a sort of catastrophe of some type that really affects all the population in some meaningful way. And maybe radiation is as bad as drinking contaminated water at one point. I mean, for the consequences that it has, it's a different type of problem, but it has probably the same consequences. But you're right. I mean, that's why environment is so important, and it has such a big play in our health. And those doctors need to know about environment. What can they do to prevent those kind of things, or to anticipate those, or to make people aware that those are conditions that should not happen?
I have read that the greatest concentration of mentally ill people in this country would be found in the penal system, in the prisons.
Absolutely.
And that they receive the least amount of care. Is that, first, is that true? And second, is it like that in other countries as well?
No. There's no country that has so many prisoners as we have. And also, actually, we had a program. We were heading a program in UCF with the Association of Medical Facilities that take care of imprisoned population. And all of that is private, which is another one of these things that you say, like, so they never want, they want to have a lot of prisoners because that way they get big contracts, right? like why is it private? And why is it like that? But all these agencies are private agencies that take care of the imprisoned population. And they, they need, they were asking us to train their managers in some kind of managerial processes so they would improve the efficiency and productivity and outcomes of the system, because there is a big problem. And people that are in prison, some have already that kind of behaviors before they go to prison, and some acquire those behaviors as they're in prison. So it's almost like some mental health facilities that some people come in kind of like okay, and then they become really, really bad because they're in contact 24/7 with those people, and they almost get contaminated by that. So those environments are very, very, very bad.
Bernardo, we'll have just time for 2 more questions.
I actually have a twofold question, so I'm not sure.
A question in 2 parts.
I have a twofold question because I've traveled the world, and what have you heard anything you can share about the correlation between the amount of vacation? Because in the States we're overworked, right? We work a lot throughout the year. We get about this much vacation. And the depression or anxiety levels, how does that compare to other countries who get, for example, Europe? They get 6 weeks. They get 2 months of vacation. In Latin America, they just get about the same, plus all the other holidays they get, right? Is there any correlation or any data that can talk about it? And then the other one would be, how does the stigma compare within the States by gender compared to other countries as well. Have you heard any of that as well? For seeking health care,
Oh, okay.
mental health care.
Yeah. I think for any kind of health, women are more proactive than men. First, they are more brave and valiant, and they go and seek health care and follow health care and go to the doctor and probably follow the treatment. And we are really very bad patients. And if you're a doctor, you're even worse patient. So we don't want to go. It hurts. I don't have time. I'm working. Come on, I'm very important. This is not important. So I think there is some popular evidence that women are better seekers of health care. And that's also why educating women when they're young is the most important thing, not so much men, because women are going to be in charge of the family. I mean, as much as you think you're in charge of your family, my wife, she needs to cover her ears now, but I'm not in charge of my family. I'm not in charge of anything in my house. So it's really my wife. So if she's not educated, my kids are not going to be educated. I am not going to be educated. I mean, she's the one kind of responsible to take care of all of us in some way. So I think women, that's very, very important. The other one was on.
The other one was there was a correlation between the workforce.
Oh yeah, and I was going to say to not worry too much. We're not so workaholic as it says there. I read a report recently of who were the most workaholic countries. Most of them are in Asia. Like Korea was on the top, South Korea, and some other countries in Asia were at the top of workaholics. They really don't take any vacation. My daughter had a doctor in Harvard in charge of the laboratory that was from Korea or one of these countries. He wouldn't stop coming to the place on Sundays, Saturdays, at night. There were no vacations. Christmas, like Scrooge, you can take 15 more minutes the next day, but something like that. So it was, and he really, that was, this is not that he was being hard with the people. He was the first one that was there all the time. So there are other cultures that have a stronger sense of that. We have that because, but it's more because of the way companies probably have more freedom to deal with that. I mean, if you look at some places, France, for instance, that you were saying, they have a 4-week day. In France, if you are my boss and you send me an email on the weekend, I can sue you, and you can lose your job. Because you interrupted my so not only I don't have to respond to your email, but I can sue you. Yeah, probably it's a good thing.
Maybe I maybe I missed this, but did you say which country you thought had the best mental health care for its citizens?
Okay, no, I didn't say which one, but in this report, what I